long way, and we are trying to find the ways to treat the untreatable or very high-risk patients nowadays. And how MRD and NGS is helping us in risk stratification of this patient is going to be the talk of today. So this diagram everybody knows, and they have seen this diagram. So if you see that in 70s, when this disease was completely incurable or less than 10% patients were curable, it has come long way. Now, even in lower middle income countries, we see the curable rates of almost 70 to 80%. And in high income countries, almost 90 to 95% of cure rates are seen in this ALL, childhood ALL, which is quite unprecedented. And so we are going to talk how we have achieved this. So first question arises in our mind whenever a child comes to your OPD with childhood ALL. Nowadays, the parents, they don't ask you whether the treatment is available or not. They just ask whether my child is going to live or not after the treatment. So that is the new thing now. And when we see the child, we think that we should have a crystal ball in our hand to tell the parents whether it is a curable or incurable childhood ALL. And risk stratify actually does this for us. So risk stratification is a key component of precision medicine, which requires the accurate measurement and integration of several prognostic factors to ensure appropriate treatment allocation. That means the patients who are having a favorable features, they should be treated with less toxic regimens to prevent the late side effects. And the patients who are having a high risk disease, they should be treated with aggressive regimens so that they can be salvaged. So, as I said, when we are talking about the curable malignancy, the first point we should come to our mind, we should prevent the overtreatment to prevent the late side effects. And if we come across the incurable malignancy, we should be aware of the relapse risk, chemo-resistant treatment failure, and increased toxicity, and accordingly, we should treat the patient. So risk stratification models, they are comprised of multiple entities with distinct clinical characteristics, genetic alterations, prognostic features, and treatment protocols. So initial risk group allocation, how we do it. We know that variables for risk stratification initially, they depend upon the clinical characteristics like age, gender, initial WBC count, immunophenotype. And how we reach this? This is a paper which was published by Children's Oncology Group in General Clinical of Oncology in 2012. And they see the treatment or the survival, treatment outcomes and the survival of the patients of different age groups in different eras, from 1994, one era, 1995 to 1999, second era, 2000 to 2005, in third era. And in all these things, eras, they found that there is a consistency. Like the patients who are aged less than 1 year, they don't do good. They have the worst survival, while the patients between age to 9.99 years is having the best survival, and the patients between more than 10 years, they are having a survival around 50 to 60%. So this gives us that the age is important criteria. Now coming to the gender, males and females. Females, they do better than males because in males, we know they are century sized like testes and they are always at high risk of relapse and they treated never on standard risk but intermediate risk protocols. Then coming to immunophenotype, B cell and T cell ALL. We know that B cell ALL patients, they do better than T cell ALL, and T cell ALL patients, they are always treated on high risk protocols. And if we combine two good risk features like age between 1 to 1.99 years and initial WBC count, this gives us a standard risk category which does better as compared to the patients who are at high risk category, that is the patients who are more than 10 years and who had a WBC count of more than 50,000. So this is our initial understanding how patients do. And when they check how the patients are doing over the different time periods, they found that the survival is improving over the time. And this may be because of not improvement in the treatment regimens, but maybe because of the improvement in the supportive care. But one thing they realize that the patients who are surviving and where they are coming back with a lot of late side effects, mainly cardiomyopathy, secondary cancer, brain tumors, and other psychosocial effects. So there was a quest to find out the patients who are less likely to fail treatment so that treatment intensity can be decreased. And because of that, more risk features or good risk features were looked into. And now they started looking at genetic makeup of the leukemic cells. They started looking at the karyotyping, chromosomal number, ploidy, cytogenetics, and other genetic aberrations. Coming to the ploidy analysis, which is a DNA index in the leukemic cells, they found there is a magic number, DNA index of more than 1.16. And from those patients who are having more than 1.16 DNA index, their event-free survival of 3 years was 97.6%, and at 4 years it was 90%. And when they combine this DNA index, which is the low DNA index of less than 1.16, with the good risk features, they found these patients had a lesser survival as compared to the patients who had more than 1.16 DNA index. So DNA index is an important prognostic feature even if the patient is having a good risk features like age less than 10 years and WBC count of 50,000. And if the patient is having a high risk features like age more than 10 years and WBC count more than 50,000 and DNA index of less than 1.16, their survival was less than 50%. So it's very important that we should have a ploidy analysis in the patients. Now, they also found that the chromosome, we know that double trisomies or double chromosome 4 and 10, if they are present, they identify very low risk B cell ALL. And they try to combine it with the DNA index. They found that the patients who had trisomy 4 and 10, with whether their index was more or less than 1.16, they do same. So a trisomy 4 and 10 is a more robust prognostic marker. And the patients who had no trisomy but having a more or less DNA index are almost doing the same. Worse were the patients who had DNA index of less than 1.16. So if you have no trisomy and you have a DNA index of less than and equal to 1.16, they are going to do the worst. Now, with all these things and with our knowledge, we know that ALL is not a single entity. It is a highly heterogeneous disease. We have B cell, we have T cell, and in the B cell also we have a highly genetic heterogeneity is present. We have hyperdiploid B cells, we have hypodiploid. In hypodiploid also we have near haploid, low hypodiploidy, and high hypodiploidy. And we know now that all these diseases are quite different. They require different treatment regimens and they behave differently and their treatment outcomes are different. Also with B cell ALL, we have recurrent translocations like we have TEL AML1, we have E2A PBX1, we have MLL2 gene rearrangements, and we have Philadelphia chromosome. And if we see the outcome of these patients, they do differently. Best outcome, as I said, like they are the patients who are having a trisomies 4 and 10 and 17, they do best, followed by TEL-AML patients. And intermediate risk is seen in translocation 119. MLL2 gene rearrangement, they don't do good. They need most of the times transplant. And Philadelphia chromosome also do worse. But now with the advent of imatinib, they are doing better. So favorable cytogenetics, ETV6, RUNX1, trisomy 4, 10, 17. And unfavorable cytogenetics is MLL gene, BCR-ABL fusion, KM2A, MLL gene rearrange, intrachromosal AMP21, TCF, PBX1. We know now this with the contemporary regimes, they do better. So hence it is in red. It is no more considered as unfavorable cytogenetic. And abnormal 17p and loss of 13q. So again, the standard risk and high risk has been redefined depending upon the age, hyperdiploidy, no century sites, and no prior steroid administration. I would say that steroid administration is an important component in our stratification, especially in this part of world, because many of the patients who come to us, they come from far-flung areas, and most of them, they are started on steroids, which are given in inadequate doses and improper schedule. And by the time they reach, most of them, they have stopped or they're taken for a shorter time. And this causes a lot of resistance in the disease, and they are always at high risk of relapse. Similarly, in the high-risk patients, T-cell ALL was considered as high risk, but now with the contemporary treatment protocols, again it is considered as not so high-risk feature. Now, we know that genetic makeup, clinical characteristics are important, but still there was a population of the patients who were not fitting into the picture. So, started looking at the response to treatment. Those patients uh, having a day 8 steroid response and post induction marrow were looked into it, and how they do was considered. So, coming to the next slide. So day 14 marrow was checked and WBC count at presentation was checked. So those patients who had WBC count of less than 10,000 and those who had M1 marrow. M1 marrow is less than 5% blast, M2 marrow is 5% to 25% blast, and M3 is more than 25% of blast. So those patients who had M1 marrow that is less than 5% blast and WBC count of less than 10,000, they do best, while the patients who had WBC count of more than 50,000 and M3 marrow do the worst, while other patients are intermediate risk, and we look further like how they can be improved and how their treatment or their risk stratification can be further refined. Similarly, day 7 marrow also is predictive. Those patients who had M1 or M2 marrow on day 7, they do better as compared to M3 marrow, who really do worse and they have a poor prognosis. Another important feature which was seen was day 7 peripheral blast. So instead of looking into the marrow, they started looking at the peripheral blast in the blood. And they found that the patients who had less than 1,000 peripheral blasts on day 7 after the prednisolone, they have almost 75% survival as compared to the patients who had more than 1,000 peripheral blasts. They had only 40% survival. So they were considered, the patients who had less than 1,000 peripheral blasts were considered as good responders, and those who had more than 1,000 blasts were considered as poor responders. So now we know that we have multiple risk features. We have NCI risk criteria, which is based on the clinical features. We have chromosome numbers, we have translocations, and we have early treatment response. And on that basis, we can define the various risk categories in ALL, which could be low risk, standard risk, high risk, and very high risk. Now, coming to the MRD, how MRD has helped us in defining further these patients or help us in defining the treatment for these patients. So, this is the landmark paper which was published by Borovis et al. In 2008 in Blood. And this paper actually established the clinical significance of minimal residual disease, and it also judged its relationship to other prognostic factors. They almost studied 2,143 patients, and they measured the MRD in peripheral blood on day 8, at the end of induction, day 29, and end of consolidation. And they found that the patients who are having a presence of MRD on day 8 as well as day on 29, they had the shortest event-free survival. They also found that the patients who had MRD of 0.01% to 0.1% on day 29 had a poor outcome as compared to the patients who had MRD negative. The survival difference was almost 30%. They also, when correlated with other prognostic factors, they found that MRD overruled TEL-AML1 and trisomies as well. In this cohort, only 12% of the patients had favorable risk factors, which included the NCI risk group, genetics, and absence of day 8 and day 29 MRD. And these 12% of the patients had 97% of survival. So now, if you look at these two columns, and if you look at this MRD-based TEL-AML, it clearly identifies the patients in among the TEL-AML who are going to do better and who are going to do worse. So whenever a patient with 1221 chromosome translocation come to us, we always think that these patients are going to do better. But now with MRD assay, we know that some of these patients can relapse, and especially those patients who are going to be MRD positive at the end of induction, and their survival can be as less than 60%. Similarly, coming to the trisomies and DNA index, If you see, double trisomies are always considered as a robust or a good prognostic feature. But when you compare it with the MRD, those patients who are MRD negative, having a double trisomies, they do definitely well. They have almost 95% survival. But those patients who are having a double trisomies with MRD positive, they don't have a survival more than 70%. And if you see MRD at different time, at the end of induction with different values, those who are completely MRD negative, they have 88% survival. And those who are MRD more than 1%, they have survival of 30% only. While the patients who are having a MRD between 0.01% to 0.1%, they have survival between 60 to 50%. Now, if you see that MRD, when it is considered with the NCI risk group, those patients, those who are having a standard risk, but MRD negative, they have 95% survival. But if they have a MRD positive, they have 64 plus minus 7% survival. While in the case of high risk patients, those who are having a MRD negative, they have almost 80% survival. And those patients who are having a MRD positive, they have less than 40% survival. And very high risk patients, those patients who are having a CNS disease, or those patients who are having a testicular disease, or those who are MRL rearrangement genes, if they are MRD negative, they have at least 70% survival. While those patients who are MRD positive, they have poor survival, less than 30% survival. So MRD then was checked at different time points, and it was found second time point was mostly at the end of consolidation, and they found at the end of induction and end of consolidation, that is time point 1 and time point 2, if the MRD is negative, they have low risk of relapse, less than 20% risk of relapse, while those who are having a both time point positive MRD, they have very high risk relapse, almost 40% risk of relapse. And those who have either of the time point positive, they have almost 30% chances of relapse. So, by doing a multivariate Cox regression analysis, in this paper, they found that the day 29 MRD is the best prognostic factor with hazard ratio of almost 4.31, followed by NCI risk group, trisomies 4 and 10, and day 8 MRD by peripheral blood. Tell AML1 and day 8 M1 marrow had no more any significant in Cox multivariate analysis. So now the question is how we should do a robust analysis of MRD. MRD can be done by flow cytometry, can be done by a PCR technique, that is real-time quantitative RQ-PCR technique. In flow cytometry, we try to target the leukemia-associated immunophenotype, and this can be applicable in almost 95% of the patient, and it has sensitivity of 10 raised to power minus 4. Advantages are that it is widely applicable, rapid, accurate, and direct MRD quantification can be done. However, disadvantages are it is operator dependent and need further standardization, and lot of expertise are required. When we do it by PCR technique, we can do it by fusion gene transcripts, or we can do it by immunoglobulin TCR gene rearrangement. Fusion gene transcripts are comparatively easier, but they are present in only 40% of the patients because we don't see too much of a recurrent translocations in ALL, childhood ALL patients. Sensitivity is 10 raised to power minus 4. Method is rapid and it reflects the leukemic clone size, but uncertain quantification of MRD is there, and it is not completely standardized in many of the labs. And there could be false positive results due to RNA degradation. And if you do a TCR gene rearrangement, it can be applicable in 90 to 95% of the patient. It is much more sensitive, that is 10 raised to power minus 5. It is widely applicable, but it is very laborious and costly. An experienced person is required, and hence it is not done very widely. So whenever we are doing a MRD detection, the MRD assays, they should allow us to detect one leukemic cell among 1,000 normal cells. That is a prerequisite. And they should reliably detect leukemic cells from the normal cells. and they should be robust enough with consistent results in different labs. And this criteria is easily seen in flow cytometry based MRD. Hence, it is commonly used now. This is yeah, interesting diagram. Actually, I just put it to show like how we do the MRD based flow cytometry based MRD analysis. If you see the first line, there is a normal bone marrow which is having CD19 and CD10 cell gated cells, and where it lies. And then when they did the gating of the ALL cells, and they found that it is quite far from the normal cells, and this is how they try to identify the leukemic clone. And if you look at the other side of the diagram, there are circles which are having a black, gray, and white circles. Those markers which are written in the black, they are actually backbone of the MRD detection. However, they are present in normal immature B lymphoid cells also. So if you use them only, then it is difficult to do the MRD detection, but these can be robustly used if MRD detection is done at day 15 to day 90. The reason being is that when we give induction therapy by day 15, along with the leukemic cells, normal hematopoietic cells are also destroyed, and there are no normal hematopoietic cells or progenitor cells that are present at that time. So whatever we are seeing at that time, if these are taken up, they are mostly leukemic cells, and the residual cells are there. But if you do it after that, mostly this bone marrow starts regenerating, and we start seeing mature cells, or immature lymphoid normal progenitors, and then it becomes very confusing. So to prevent that confusion, then other lymphoid associated immunophenotypes were seen. The gray ones are the first generation, and the white ones are the second generation leukemia associated phenotypes, and these had been designated by gene array methods, and by this we can do a MRD detection. So post-induction reassessment or final risk group assessment is done by MRD analysis. We know that now that peripheral blood MRD at day 8 less than 0.01% is favorable, and day 29 less than 0.01% is favorable. While unfavorable is M2, M3 peripheral blood MRD on day 8, or bone marrow MRD on day 29 more than 0.01%. So NCI risk stratification, this is a busy slide, but this does show how to apply the various MRDs in various risk categories. In the standard risk category also, they started to divide between low risk and average risk depending upon the MRD results available. And then in the high risk, they started dividing into high and very high risk group depending upon the MRD results. And in very high risk, they also included the adverse characteristics like MLL gene rearrangements, hypodiploidy, intrachromosomal amplification 21 chromosome, induction failure, and pH positive and pH like cells. And any patient who was more than or equal to 13 years of age was also considered as high risk in this stratification. Then in COG group, they had 4 risk categories initially. Then they started on the basis of MRD, they divided these patients into low risk, standard risk, and high risk. So standard risk, as per the NCI risk criteria, with double trisomies or TEL-AML1, if they had MRD negative, they were considered as low risk. If they had day 8 MRD positive, they were considered as standard risk. And if they had day 29 MRD positive, they were considered as high risk patients and were treated on high risk protocols. So, similarly, in standard risk patients, those who had no double trisomies or TEL-AML1, they had final risk stratification post-induction depending upon the day 8. If it is less than 1%, standard risk. If it is more than 1%, high risk. And if MRD at day 29 more than 0.01% was considered as very, very high risk in standard risk patients. And in high-risk patients, there was no standard risk category. Those patients who had MRD negative, they were continued on high-risk protocols. And those patients who had MRD more than 0.01%, they were considered on very high-risk protocols. And those who were treated on very high-risk protocols, all of them were the candidates for bone marrow transplant. Similarly, BFM 2002 also incorporated the early bone marrow response remission status after induction therapy, and minimal residual disease in the bone marrow in their schema. Now, St. Jude Total 15 protocol, they started incorporating MRD assessment in their treatment protocols. So the patients who had day 19 MRD more than 1%, their treatment was intensified. They did repeat MRD on day 46. Those patients who were standard risk ALL but MRD positive of 0.01%, they were treated on high risk protocols, and those who had more than 1% were treated on very high risk protocols. And at any time point in the continuation therapy, irrespective of the initial risk category, if the MRD was 0.01%, they were considered as very high risk and they were assigned for transplant. So monitoring the response to MRD, it actually addresses the issues raised by both the heterogeneity of ALL and host diversity, which means that we know that the various subtypes of ALL are present, and there is a host diversity in the as pharmacodynamics and pharmacogenetics are different for different patients, and it raises both the issues. It addresses both the issues because it is a response to the treatment ultimately, and that is assessed by the minimal residual disease. Hence, it is indeed a strongest prognostic factor in ALL. It guides the treatment intensity assignment in ALL, and MRD measurements can also be used as surrogate endpoint for innovative drugs. And it is now a routine clinical practice and a standard of care. So another busy slide just to show that how our risk stratification is changing. So on the basis of demographic and clinical features, now we are no more considering gender and ethnic groups as a high risk features. We are only taking age and initial white cell count. Then immunophenotype definitely is used to select the therapy backbone. Among these cytogenetic features, we see that if there is a MLG rearrangements and hypodiploidy present, they are the candidates for the transplant. Then we look at the genomic features like Icaros mutations or deletions, and those patients who are having Icaros deletions, and especially if they are PH-like ALL, they are assigned for more intensive therapy and even tyrosine kinase inhibitors. Then third part is early response to treatment. We look at the glucocorticoid therapy, we look at marroblast, MRD quantification, and MRD at 3 to 4 months. And these all help us in intensifying the treatment in many of the protocols, and in some of the protocols they do decrease the treatment intensity also, so that to prevent a late or other side effects of the treatment. So the landmark in understanding the biology of acute lymphoblastic leukemia, in 1960s we had first cytogenetic study done in ALL. In 1970, first report of Philadelphia chromosome positive ALL came. In 1973, first identification of T-cell ALL happened. In 1978, classification of ALL by chromosome number was done. In 1980s, immunological monitoring of residual leukemia happened. In 1984, first identification of immunophenotype specific chromosomal translocations were seen, while in 2000 we saw first genome-wide profiling of gene expression. 2007, first genome-wide study changes in DNA copy number. In 2009, we saw germline genetic variants, and in 2012, first whole genome sequencing study to identify the driver mutations in ETP-ALL was seen. So over the period, we are seeing a lot of understanding of the biology of acute lymphoblastic leukemia, and with the efforts of multicentric and collaborative trials, we are able to incorporate this knowledge in improving the treatment regimens of our patients, and definitely it is showing in better outcomes. Now, just giving you a case scenario, a patient who is borderline age, like 10 years, gender male, who is having a WBC count at presentation of 16,000, his bone marrow had 51% blast, and flow cytometry was B-cell ALL, and cytogenetics was normal. So to start with, this patient considered, except from male, which is now no more considered as a risk feature, we don't see any high risk feature in this patient, and this could be from standard risk to intermediate risk in this patient. But he had a poor prednisolone response, and he had a blast count of more than 1,000. Now, by the middle of induction, we had another report of this patient, and we found through NGS that this patient is EBBF1 PDGFR beta translocation positive, which is like seen in Philadelphia like ALL, and hence this patient was started on imatinib. And because of that, patient at the end of induction was MRD negative, considering that we treated this patient on high risk protocol then. So has to be additional measurements to identify the patients who are at high risk of relapse. We have seen MRD, we have seen the other clinical characteristics, but still we are not able to identify all those patients who are going to relapse. And if there is anything which we can do to salvage these patients. So genome-wide study of genetic alterations has been done. And we see recurrent genomic alterations in childhood ALL. The first column shows a B cell ALL and then T cell ALL. If you see the majority of B cell ALL, they have hyperdiploidy, they have ETV6, RUNX1 translocations, followed by other known translocations, and then many other translocations are there, and pH positive or pH like are also seen in T cell ALL. And in T cell ALL, we know ETP ALL is an important component and is a high risk feature. So when we see these different translocations or genetic aberrations as per the age group of the patient, we understand that why the patients who are less than 10 years are having a good prognostic features. Because the patients who are younger, like who are considered as standard risk, they mostly have a good prognostic translocation, that is ETV6 RUNX1. And as the child grows older, or as the age increases, like the child from adolescent to young adult, if you see this blue box, which is like PH-ALL, the percentage of the PH-ALL, which is having a poor prognosis, or those who they are resistant to the treatment, their incidence is keeps on increasing, and that's why this age group does poorly as compared to the lower age group. And hence this gives us insights into the pathophysiology of ALL. So this paper was by Dr. Mulligan and Dr. Stephen Hunger. They said that redefining the ALL classification, which is a step towards detecting high-risk ALL and implementing the precision medicine, actually, which is a demand of the day. They found that there are several ALL subtypes, and there are several cellular pathways which are involved, especially the kinase activating lesions and genetic alterations are present in these cells, and these should be identified because these can be the logical target for new precision medicine therapies. And they have done a sequential sequencing of studies at diagnosis, at remission, and at relapse, and which has provided an important insights into the relationship among genetic variants, clonal heterogeneity, and risk of relapse. And hence, we are much more wiser, and we know which treatment approaches can actually benefit these patients, and where we need to intensify the treatment. And now we have many of the targetable drugs are available which can be used in this population. So coming to the pH positive or pH like ALL, we know that these patients have multiple common alterations like IGH, CRLF2, then they have PDGFR beta rearrangement, which was seen in our patients. Then they can have APOD, JAK2 rearrangements. Depending upon that, they can be various targeted therapies can be used. For CRFL2, we know that they can be targeted with TKI inhibitors. PDGFR beta again can be treated with the TKI inhibitors. JAK2, we know that we now have ruxolitinib and JAK2 inhibitors are there, which can be used in these patients. And definitely, chemo resistance can be decreased by using these targeted therapies for these patients. Similarly, other rearrangements can also be looked in carefully, because many of these are highly chemo resistant and they can be candidate for a transplant upfront only. while other rearrangements can be targeted, like um, we have this monocyte factor 2D rearrangements. These can be treated with epigenetic therapies, like histone deacetylase inhibitors can be used in these patients, while we have zinc 4 rearrangements. If they are present, they can be used to JAK inhibitors, and in some of the papers, even FLT3 inhibitors can have been used for these rearrangements. Hence, with the drug availability and other therapies, I think these rearrangements now need to be seen, and NGS is helping us in a big way to identify these rearrangements. Similarly, with T cell ALL, we have many this fusion genes are present, but many of these are having an unfavorable prognosis, and none of targetable lesions are present so far. So they are not looked so much into it, but the knowledge and understanding of this is important, because over the time, definitely we'll have something more for these patients as well. So this is a diagram. Again, this was published by Dr. Mulligan in Genomic Analysis of Acute Leukemia. And this is a very interesting diagram to show how the various mutations act at what level and why they are more serious. So if you see the Icaros mutation, it is at a very progenital level. It is at the stem cell level only. Sorry, and that's why these can be seen in various Icaros mutation can be seen in T cell, it can be seen in myeloid cells, and it can be seen in B cells also, and they are very resistant to the treatment, and hence carries a poor prognostic feature. Similarly, E2A, EPVF1, they are present in at the pro-B and pre-B1, and they prevent the differentiation of these early progenitors into a mature cell, and there is a leukemogenesis happens. And this is the diagram which actually shows quite neatly and clearly this method. So now this is a schema which shows a genetic pathogenesis of B cell ALL, and it shows the relationship of development of ALL and treatment failure. So if you see, there is a lymphoid progenitor, and there is an initiation lesion happened, leading to arrest development, self-renewal, and activating signaling. But epigenome could be there, and there could be a disposition of inherited variants like Icaros, CDK2NA driver mutations, GATA3 mutations can be present, leading to a developmental arrest, and hence mature B cell is not formed. Then when there is a maturation arrest is there, then there could be cooperating events happening, which could be mutations in the tumor suppressor genes, RAS signaling pathways, lymphoid signaling pathways. There could be mutations in the epigenetic regulators, leading to a ALL diagnosis. And among this, there could be a selective pressure of the chemotherapy, leading to a conferring the resistance to the therapy to those cells who are having these epigenetic TP53 or Icaros mutations, and hence leading to a ALL relapse. Hence, this whole thing actually helps in improving our understanding of ALL and ultimately ALL relapse as well. So this is another diagram which shows PH-ALL, the various translocation, various types of mutations which are present in the PH-ALL and targeted therapies. So if we see that ABL1, ABL2, CSF1R, PDGFR beta can be treated with dasatinib, then CRLF2, JAK2, BOR can be treated with JAK2 inhibitors. Then we have other NTRK3 kinase rearrangements which can be treated by crizotinib. So knowing this translocation, addition of this therapy definitely help us in treatment of these patients. So now, simplifying the things, the risk assessment with MRD and genetic factors, how we can incorporate. It has been seen that the patients who had favorable genetic factors, and if their MRD is undetectable, they have risk of relapse of almost 3% only. But if their MRD is detectable but less than 0.01% with favorable genetic factors, the risk of relapse is 4%. And if MRD is strongly positive with favorable genetic factors, it is 6%. But now coming to the unfavorable genetic factors. even the patient who is having a MRD undetectable but having a unfavorable genetic factors, they have almost 12% risk of relapse. And if MRD is less than 0.01%, with unfavorable, the risk of relapse is almost 50%. Now, coming to the third category, where the MRD level is high with unfavorable, we see only 10% of relapse, because this is a study population where they were treated with very high intensified high risk therapy based on these factors, and hence they were salvaged, and hence we did not see too much of relapse in this patient. So this is an intervened or population where treatment was already given, and which actually signifies if we know these factors, maybe we can change their risk of relapse and salvage them much better. Hence, the knowledge of these factors helps in intensifying the therapy for patients with detectable MRD. It is important of combining the traditional risk factors, especially genetics, with MRD to determine the true relapse risk after achieving the remission. So, although the risk of relapse was directly proportional to MRD level within the each genetic risk group, the absolute risk of relapse that was associated with specific MRD varied by genetic subtype. And patients with MRD levels at either end of the spectrum had similar outcomes regardless of genetic subgroup, whereas the outcome that was associated with moderate MRD levels with genetic was genetic subtype dependent. Hence, knowing the genetic subtype and MRD both together is important to understand the risk of relapse in these patients. So this is a recent paper by Dr. Pui, which is published in April in 2020, and it has shown how they have incorporated the provisional high-risk features, genetic high-risk features, and MRD in ultimately deciding the patients in high-risk and very high-risk categories, and considering their checking their event-free survival and overall survival. So, not going into details of this, these are the completed trials of risk stratification, and these are the current trials in which they have how they have included. They have included the high risk factors, they have included genetic risk factors, they have included the MRD level, which is at the end of induction, and in very high risk, they have included who are having a persistent MRD positive at the end of consolidation. Also, they were treated as very high risk group. And similarly is the case of various other groups also. So now coming to the NGS, how NGS is helping. As I said before, that NGS is helping us in identifying the various genetic subtypes of the ALL patients, and it is also helping us in doing the MRD analysis. So if you see the above graph, which is the MRD done by flow cytometry, it is having a sensitivity of 10 raised to power minus 4, and it is not showing much difference between the two groups, that is standard risk and intermediate risk groups. But if the same population of patients had done MRD analysis by NGS method, which is having a 10 raised to power minus 6, we see a major separation between the two. So there is a clear demarcation of the patients among in the standard risk also, those who are at the high risk for relapse or having a poor prognosis came in this red line, and that's why we are able to see a good gap between the two, and this helps us in identifying the patients who are having are at more risk of relapse. So limitations, now we are knowing that with the flow cytometry, the expertise and standardization is required, and with RQ-PCR, it is time consuming and laborious. And NGS is much user friendly because it uses universal primers, and it is having a high, and it is clinician friendly also because it is having a higher sensitivity of 10 raised to power minus 6, which helps us in better identification of the patient who are at more risk of relapse, and those whose patients who are very less or risk of relapse or very favorable risk of group of patients. So NGS, this is a diagram to show that NGS at various time points of survival analysis was done. It was seen that the patients who had MRD, NGS MRD negative on day 23, there was not there was not much demarcation was seen, but if you have a persistent NGS positivity on day 80 or 4 and 5 months, then these patients definitely do very poorly as compared to those who are having the MRD negative. So this will actually help us in identifying a lot of population of the patients who have late relapses, and then these can be intervened early to prevent a relapse. So this is a multivariate analysis. In this, the same thing they have shown that the MRD analysis, those who are having a low positive or high positive has a better prognostic significance as compared to any other risk factor. So redefining the ALL risk classification, now we know that ALL is a heterogeneous disease. Improved understanding of the disease leads to better outcomes as seen over the years. Integration of various factors actually helps in robust risk stratification. Practicing methods to identify new subtypes of ALL lacking gross chromosomal alterations is important to identify high-risk patients with targetable lesions. Monitoring MRD has become indispensable, whether it is done by flow cytometry, NGS, or RT-PCR method. Current methods have limitations, and with advent of NGS, we may soon its incorporation in the clinical trials. And most importantly, the hope is that over the years, we will achieve near 100% survival, and very few will require transplant with the help of administration of monoclonal antibodies and other targeted therapies. Thank you.
Was a very lucid presentation. It is a bit heavy to digest in such a short span, but I think that so very lucid and powerful presentation. Can you please? Yeah, that's what I wanted. Let's take questions.
Yes.
Can we have? The first question is from Sneha. If we need to do MRD twice, what will be the best time in BLL and TLL? And is it different for adults and children?
So actually, it all depends upon your treatment protocol, which treatment protocol you are following. So depending upon that, you need to do your MRD analysis. Most of the protocols they follow MRD analysis, which are done at 2 time points, is at end of induction and end of consolidation. And some protocols they are doing MRD at day 15 or day 19, followed by end of consolidation as a second time point. While in B cell ALL, we can follow the end of induction and end of consolidation time points. And in T cell ALL, since we know that there is a late clearance of the blast cells, mostly time point 2, that is end of consolidation, is considered as a more robust prognostic indicator of the treatment response.
What do you prefer in your practice?
So in my practice, actually, I'm doing for B cell ALL patient, for all patients, we are following BFM 2009 protocol, which is day 33, MRD analysis is done in these patients, and on that basis, we do the stratification.
Day 33?
Yeah.
Yeah, so now if you have a specific chromosomal abnormality or cytogenetic abnormality, what do you follow? The complete flow cytometric analysis, or do you look at specific genetic abnormality for MRD?
So actually, if there is a fusion transcript is available, then following it by a PCR method is a good way to find out the remission status. But MRD actually is a very robust method. So mostly the fusion transcript by RT-PCR is not available. I think Tata was doing initially, and we were sending sample for that, but we were seeing it correlation with the MRD analysis by flow cytometry. So after that, we stopped doing it, and it is not done very regularly. Hence, I think MRD in clinical practice, we are just following with the MRD only. But now with the advent of NGS, definitely, and we are seeing other aberrant abnormalities or genetic subtypes. And if these are identified in the start, I think MRD can be done by NGS method also at the end of induction or end of consolidation to see whether the patient is in complete remission, because this will tell us the depth of remission also in these patients. Then.
Right. Now, the next question is again by Sneha. What is the minimum number of events required to interpret MRD?
Okay, I think I'm not the good person to tell this thing. This will be told more by the technical person. But I think more than 1 lakh events are actually required for to have a good MRD analysis. And most important thing is that from the clinician point of view, how you collect the sample for MRD analysis is important. So whenever you are doing a end of induction bone marrow, try to collect only 2 ml of bone marrow, not more than that, and try to give that 2 ml in different EDTA tubes and send it for MRD analysis. So that is more important. But I think it's at least 1 lakh events we require to require.
Right. Kripa Bajaj asked a question. I think it's probably extension of what I just asked. Can you please elaborate on molecular MRD?
Molecular MRD.
Man, usually in we used to we prefer to do molecular MRD when there is a pH positive ALL. So is it like really required for all the ALLs who are having a molecular abnormality to repeat the MRD by NGS? Or one more question is, will you send for all patients upfront for NGS to see the molecular abnormality? Or
second question, I'm not able to hear. Sorry.
Will you do you send all patients upfront for MRD for molecular analysis upfront in ALL, ma'am?
So for the molecular, that is by NGS method. Actually, NGS method is a very new method, and we are still not incorporated it completely in our protocols. But I would say like now we have started sending our samples for the patients, and I would say like I gave one case scenario, it actually helped in managing that patient. So those patients, so we do see surprises, and if NGS facility is available, I think we should send the samples because it will help us in identifying the genetic aberrations which are not seen by fish, cytogenetics, or other methods. So molecular NGS, if it is available, it should be done. And second question, sorry, I'm not able to understand.
If you find any molecular abnormality upfront, so do you monitor all cases with NGS or only specifically like with PCR, how you monitor pH positive ALL?
So those patients who are having a genetic aberration at the time of diagnosis, they can be followed by the NGS method to see whether there is a remission or not. That should be done.
I think what she probably means asking is, should we do NGS upfront for everybody? Yeah, for all the patients.
Yes, we should do. If the facility is available, we should do it for all the patients. Especially, I would say those patients who are having a NCS standard risk criteria, maybe they can be. If the cost is a problem, then they can be. We can not do in those patients, but those patients who are more than 10 years of age, because we know that the pH like ALL is much more common and there is an increase in frequency of these patients, NGS should be sent for these patients.
I think in our country where finances could be a problem, you just mentioned in the MD spectrum, at the either end of the spectrum, cytogenetic or molecular abnormalities may not really matter, but it's in the middle part wherein the cytogenetic or molecular abnormalities make a lot of difference. So maybe if there's a finances problem, we do a day 29. And then if they at the other end of the spectrum of MRD, you send NGS. Does this sound a good idea? What do you think?
I'm not very sure actually whether you'll be able to identify that targetable lesion at that time or not, whether there is no alteration or not. So I think for that we can have again the lab person to tell us, because as you are saying that those patients who are MRD positive, maybe for those patients we can send the NGS at the end of induction and see whether they are having a targetable lesion or any other abnormal translocation. So maybe you can keep the sample or you can do the DNA extraction of these samples, keep it aside, and then if there is a MRD positive, you can send the diagnosis sample for the further
I think that makes sense. So that we can sort of conserve the resources.
Yeah. So it can be done like that.
Right. Suhas Kirti Sangla has asked the question. When do you suggest to do a marrow, bone marrow to be done? This bone marrow examination to be done.
Bone marrow examination for what?
I think Suhas, you can elaborate the question if you want. That's what you written. When do you suggest bone marrow examination to be done? Do you mean for MRD? What do you mean? You can unmute yourself and ask Suhas.
Yes, sir, for MRD purpose only.
So, as I said, like MRD purpose, it depends upon your treatment protocol and how you're going to modify the treatment. So, many treatment, many this, trials, or the treatment protocols, they do MRD at day 14, they do MRD at day 19, end of induction and end of consolidation. What we are following is that we are doing MRD at the end of induction and end of consolidation. We are not doing it at day 15 and day 19. I hope this answers your
question. Okay, yes, ma'am. Thank you, ma'am.
There's another question from Rohan. What is the role of MRD assessment post-transplant in pH positive ALL?
Post what?
Post-transplant MRD assessment in pH positive ALL.
So
I think we can probably take it more generalized, maybe PL positive or any ALL high risk which has got a known translocation, probably. Maybe you may just ask the question.
So those patients, I mean, post-transplant, definitely for those patients, MRD assessment can be done by following the BCR-ABL1 translocation by RQ-PCR, which is a very robust method and easily done. So post-transplant also we need to follow these patients, and any patients who are having a MRD levels at a detectable level, then these patients will require either DLI or further management of these patients. So this will help us in defining the treatment for these patients post-transplant as well. And other patients also who are having a known translocation, stable translocation, they can be followed by the MRD analysis depending upon what kind of a translocation is present. Whether it is by molecular method or if there is no recurrent translocation, then we do follow these patients MRD by doing a flow cytometry up till 6 months to sometimes 1 year, depending upon the risk category of these patients.
Yeah, right. That's what I was going to ask. What is the timeline? What is the usual protocol timeline you do the MRD assessment after transplant?
Yeah, mostly 6 months. So 3 months, 6 months, and then 1 year.
Right. And what is the trigger for DLI? If you find the MRD positive, at what point or any time? 3 months, 6 months, or does it change your management?
So DLI can be given at on the two bases. One is that those patients who are having a recurrent translocations like pH positive ALL, if their MRD starts coming positive, then DLI can be given. And second is that if the patients are followed on chimerism, and if their chimerism starts falling, then also we can give DLI for these patients after doing their bone marrow and molecular status also.
Madam, in a pH positive ALL, how frequently you give DLI and salvage that small molecular lapses? We find that most of the time when the molecular lapses happen, even after DLI, they keep on collapsing.
Yeah.
We don't find any good graft versus leukemia effect, despite there's a chimerism 100% or 99%, and with the small increase in molecular lapse, when we find it and we give DLI, we find that they relapse on the top of DLI, irrespective of what the DLI is there. So, you think that the DLI has a very good role in pH positive ALL?
Yeah. So, definitely, the DLI, it depends upon how was the MRD before before transplant also. If it is completely MRD negative patient and has been undergone transplant, and if you have continued the TKI therapy in these patients post-transplant, sometimes they can be salvageable with early DLI. So there is a role of a prophylactic DLI and there is a role of prophylactic DLI also. Those patients who are very high risk of having a relapse and having a pH like this thing. So starting giving a prophylactic DLI at day 40 or day 45 also has a role in which has been mentioned in the literature for these patients.
Most of such patients do have that P315I mutation and pH positive ALL.
Yeah.
Post transplant. Unfortunately. What is the NGS panel do you send, madam?
NGS panel.
Of genes.
So we just ask for ALL panel for these patients, and we just inform that this is a B-cell ALL, and they do the complete panel for us.
Okay.
The next question is from Kripa Bajaj again. In your center, will you send molecular analysis upfront? I think she asked that question. Is it okay to avoid doing bone marrow examination till MRD undetectable in favorable risk group?
So not to do MRD at all in these patients?
No, not to do bone marrow examination till MRD is undetectable.
Since once it is less than 0.01, is it really required to do repeated bone marrow till it is undetectable? Because 2% benefit is there. I mean, we see only difference of 2%.
No. So we don't do it in our patient population, because the risk of relapse is very low and it doesn't benefit much to the patient. We don't do it.
In high risk, ma'am?
In high risk patients, definitely we do it. So in high risk patients, we do it different time levels, end of consolidation, and even we do it at the start of maintenance treatment for these patients. If they are MRD negative, but still we do at the start of maintenance also, just to check how they are doing.
Thank you.
I think now this is the last question today from Dinky Gajuwala. For which method is preferred for MRD? RQ-PCR or flow cytometry?
Okay. So RQ-PCR and flow cytometry is having almost similar sensitivity, but RQ-PCR is much more laborious if it is done by TCR rearrangement method. But if you are having a fusion transcript which can be checked by RQ-PCR, it is good method. It can be done by that method. But if you don't have fusion transcript method, then I think flow cytometry is much better and much more widely available, and it is actually very easily done nowadays. So that should be the preferred method.
I think that gets us to the end of the talk. Thank you very much for this wonderful talk. It is a difficult topic for most to understand. It is ever evolving.
Yes.
As we are able to learn more and more about the cytogenetics, molecular abnormalities, newer drugs are coming up. So I think yesterday is long distant and tomorrow is today. So that's what is happening. Especially in ALL, we were talking about cure rates, and now we are talking about reducing morbidity. So I think this MRD has a long way to go. Thank you very much for being with us and answering questions of all the students. We hope you have some pediatric talks with us coming up as well. You have been helping us to arrange and inviting friends to give pediatric talks. So thank you very much from all of us, and good night.
Thank you so much, sir. It's been a privilege, actually. I really felt nice, and it's been a privilege and honor to be here. And thanks for giving me the opportunity for being here. Thank you so much.
Thank you very much, and good night. And good night, everybody. See you next week, Tuesday. I think next Tuesday is probably early. It's, I think, 6 o'clock to book your calendars. I'll share the link early this time so that you can arrange your calendars. Thank you.
Thank you so much. Thank you. Good night, everyone.
Good night.